Good morning, everybody. Welcome to this breakfast CME of Allahabad Medical Association. The topic today is practical tips on early diagnosis and management in renal disorders. I think this is one topic which is useful for practitioners of all specialties and the general practitioner as well, because I think whosoever is in medical practice should have an idea on early diagnosis of renal diseases, because the earlier the diagnosis, better the prognosis. I now hand over the mic to Dr. Anubha to conduct the proceedings. We have a very distinguished speaker, Dr. Sanjeev Gulati, who is Chairman Nephrology and Kidney Transplant Fortis Group of Hospitals in NCR, and an equally eminent panel of chairpersons who shall be highlighting and discussing the tips on early diagnosis and management of renal disorders. Dr. Anubha.
A warm welcome to all the delegates for a wonderful breakfast CME, and I would assure you it would be a great feast. Dr. Sanjeev sir has requested for this breakfast CME. I think sir has been prior to our breakfast CME. Yeah. And this, because we have an option of having it as a dinner CME, but sir also said that this is one of its kind of a breakfast CME which is done mainly by Allahabad branch of IMA. So we invite you, sir, and thank you for coming over and talking on a very important topics. As Sujit Singh sir very well explained, the importance of early diagnosis management in one of the commonest indications of hospitalization in day-to-day practice, which is chronic kidney disease. So without wasting much time, I would like to start our scientific session with inviting our chairperson for today's session. Sir, can we start our scientific session? I would request Professor Arvind Gupta sir, Dr. Anurag Singh sir, a renowned nephrologist of our city, to chair our session, and I would request Dr. Mannani sir to also chair the session. Would request our chairpersons to introduce our speaker and invite him to start the session.
Good morning, sir. I am Dr. Arvind Gupta. Welcoming you for this glorious meeting. This is presented by my teacher when I joined as a teacher at that time, so his teacher and he has very long list of resume, 150 papers. The process in Fortis Group of Hospitals, NRC. Sorry, NCR. One point I want to highlight that it is basically based on the pediatric nephrology. We have the basic thought, and it is with pediatrics. We get into pediatrics and then it is urine nephrology. So we regarded as a father of pediatric nephrology from India. So I welcome and request to come and present your talk.
Thank you, Arvind, and good morning, everyone. I think it's a great honor and privilege to give a talk at this breakfast CME. I've had one previous occasion. I think this is one of the most well-attended CMEs and very interactive sessions. It's another honor to come to Allahabad as two of my brightest students are here, and they have brought us great pride. Dr. Arvind Gupta, who started the nephrology service here, and subsequently Dr. Anurag Singh, both of them have really made excellent contributions to the nephrology service in this part of Uttar Pradesh and brought laurels to SGPJ. So the topic I've chosen is chronic kidney disease, practical tips on early diagnosis and management. Now, this is a quote by Alvin Toffler, and this quote applies to doctors that illiterate of the future are not those who can't read or write, but those who cannot learn, unlearn, and relearn. And in that sense, I think there is no doubt that doctors are one of the most literate members of the society. Even on a Sunday morning when most the people would be at home sipping a cup of tea or relaxing, we are all gathered here just to try and upgrade our knowledge. And this is a regular feature that we do. So, chronic kidney disease. Why I have chosen this is because when I was doing my MD training, the moment we used to get a high serum creatinine, we used to just, our thought process literally used to stop and we said, just call the nephrologist. But all over the country, we just have about 2,000 nephrologists, and even in this city, you just have about 3, if I'm not wrong, 3 or 4. Yeah, recently there's a 4th one who was joined. So they cannot alone handle the load. And if we know that we are in an epidemic of chronic kidney disease, so if we have to look especially at the preventive aspects, I think it's a job of all the, whether it's a physician, surgeon, everyone needs to know about chronic kidney disease so that we can prevent comorbidities and improve the outcomes of our patients. And I'll show you how over the next half an hour or so. First of all, let's try and understand what do we mean by chronic kidney disease today. Well, in simple terms, it means abnormalities of kidney structure. So with structure on an ultrasound, so if you have either a contracted kidneys or function. Function is EGFR. So we talk about percentage glomerular filtration rate with implications for health. So either of the following must be present, but for more than 3 months. So one isolated reading is not good enough. So you have albumin creatinine ratio more than 30 milligram per gram, markers of kidney damage 1 or more, or GFR calculation of less than 60. So if you have any of these, then this, and it is confirmed over a period of 3 months, that this patient has got chronic kidney disease. Now, as your president just said, that it is everyone's problem. Surgeon's problem, because if this patient has perioperative renal dysfunction and you have inadvertently given non-steroidals, the kidney function is going to worsen. It's going to end up in acute kidney injury. Fluid and electrolytes are also an issue. You have to make sure that you don't get into hyperkalemia, fluid overload. Anesthetists, again, fluid and electrolytes need to be prescribed as per the underlying degree of renal dysfunction. For physician, besides all this, drug dosing. So most of the drugs require drug modification as per the EGFRs. For the obstetrician, directly the outcome in pregnancy is directly related to the degree of kidney function prior to conception. Whatever the underlying disease, whether it's SLE, whether it is diabetic, the EGFR correlates very well with the outcomes, and that there might be times when the obstetrician has counseled the family against going in for pregnancy, but then you need to know the underlying kidney function. For the radiologists, if they have inadvertently, the patient comes to them, they do an IBP or a urography without doing the EGFR, these patients can land up in contrast nephropathy. For the intensivists, again, fluid electrolyte drug dosing. Cardiologists, again, taking them up for an angiography without EGFR. I think I am aware of several instances a few years back, I mean, maybe a couple of decades back, where when I remember when I was in HCPGI and we had a couple of patients who did not, the patient came directly and the cardiologist, as usual, they are very enthusiastic in getting it. Their focus is mainly on angiography, but these patients ended up on dialysis, acute kidney injury. So at least in our hospital now, it is mandatory. You cannot get a contrast procedure either by a radiology or by a cardiologist without getting your EGFR. We are not happy with this serum creatinine. Even they'll tell you, please get your EGFR done. And we'll visit this later. First of all, one of our patients, when I first joined Vasant Kunj, this was in 2007, a 44-year-old lady presented to the emergency with breath-resistant accelerated hypertension. When we went back into the history, in 2003, she had severe hypertension. And other than a brief non-invasive cardiac evaluation, nothing else was done. But when she came to us, she had stage 5 kidney disease. We initiated on dialysis and we quickly got her onto a kidney transplant in 2007. Husband donated the kidney. As you can see, she's 15 years post-transplant. And she comes once in 2 to 3 months for a follow-up. Subsequently, it was amazing. She actually did her PhD and is now teaching in a college in Agra. So from a school, she actually went ahead with further medical education, has got her girls married. So that's the quality of life a kidney transplant can give you. But she asked me, could something have been done earlier? And the answer is yes. If it's 2003, somebody had got a kidney functions done, I'm sure we would have added years to life and life to years for this lady. Another patient, a 50-year-old diabetic, many of you would see such patients, comes to you with history of swelling of weight, diminution of vision, headache off and on, severe hypertension, anemia, edema, fundus shows retinopathy, serum creatinine of 4.4. Unfortunately, serum creatinine gives you a very small number, which these patients, their attendants do not take it seriously. But when you do a EGFR, it just means that this patient has got only 22% kidney function left. And that's why it's mandatory to do these EGFRs. This patient has got diabetic nephropathy. He could land up with, as Dr. Sujit said to him, with a right inguinal hernia. So unless and until you do an EGFR, you won't know. Land up in one of the medical wards with an acute gastroenteritis. This EGFR, I'm sure, will come down to 10, might even require dialysis temporarily. Could present to a cardiologist for angiography. So unless he knows the EGFR, he will not give perioperative hydration, give contrast prophylaxis, but also to a radiologist for a CT scan. Now, this is a patient which was referred to us by one of our physician colleagues for a consult a few years back. 63-year-old male, diabetic for 9 years, edema, just presented with edema. Blood pressure 130 by 80. He had done a microalbuminuria, it was negative. Serum creatinine of 1.3, ultrasound showing normal size kidneys. So he asked me, is this edema renal in origin? So essentially what he was asking me is, does this patient have kidney disease? And again, we'll take it up later. Now, I've divided my talk into 3 halves. We'll look at early diagnosis, look at kidney function test, very simple and easy to do in any part of the country. Look at clinical approach and lastly discuss options for renal replacement therapy. Now, urine analysis, I think, is still one of the most important, one of the simplest tests that gives us some indication of the underlying kidney disease. If in the first morning specimen, the specific gravity is 1010, which means this is a dilute urine. The normal specific gravity should be more than 1025 or ideally 130 because this is a period of fluid deprivation. So you should be able to concentrate the urine. So if the urine is dilute, and that is one of the earliest markers of kidney damage, dilute urine, it suggests that this patient has got kidney disease. Albuminuria is again a hallmark of kidney disease. Very simple to do. Urine sediment, if done properly, gives you a wealth of information. If you see RBC cast, glomerulonephritis, WBC cast, acute pyelonephritis, broad cast, chronic kidney disease. But more often than not, you have patients walking into your OPD with a urine showing NAD, because urine is not given the respect it deserves in a pathological laboratory. And the laboratory is being very honest about it. The NAD is not adequately done. It doesn't mean normal. So that's why if you suspect, if there is a disparity in the clinical picture, and Arvind will vouch, both Saurabh, Anurag and Arvind, we used to look at urine ourselves. in our side lab. We used to say that something is missing. We never used to, even in SGPJ, we never used to trust the pathologist, because by the time the sample they collected, it has gone to the laboratory. We don't know who's seeing it, and some of the sediment is gone. So always do a urine yourself if you are suspecting. Now, urine albumin quantification, I think, is one of the most important tests if you are looking at kidney disease. Earlier on, I remember we used to hand over cans to our patients, bother them with a 24-hour urine collection. And if you ever tried it doing yourself, that is one of the most difficult tests. And that's why it's so inaccurate. But studies have shown that a spot urine albumin creatinine ratio correlates very well with the 24-hour urine albumin excretion. So no longer you have to burden them. And these are the readings. Less than 30 milligram per day is normal. 30 to 300 is microalbuminuria, which is actually the earliest evidence of kidney disease. And macroalbuminuria is more than 300 milligram per day. So just the first morning specimen, a spot urine sample, but yes, there are certain caveats. So it should not be given during a period of fever, because just a UTI can cause microalbuminuria, or after a morning session in a morning brisk walk, or a session in the gym, because exercise can cause albuminuria. So these caveats should be explained, and the first morning specimen is good enough. And if you have that, it should be done in diabetics, 5 years of onset, once in every year at the time of diagnosis, and once a year in non-insulin dependent. And as I said, fever, heavy exercise, infections like UTI can cause microalbuminuria. That's why if you find it once, just reconfirm it again. And anyway, you need to have readings over 3 months if you have to make a diagnosis of chronic kidney disease. So this earlier on, I remember my time when I was doing my residency, and we used to believe in serum creatinine and urea as the gold standard for diagnosing chronic kidney disease. But this chart shows you that what we believed was gold is not really 24 karat gold. Why? This is the GFR here on the x-axis. So this is 120, 100 to 120 is normal. And this is the GFR declining here. So this is the serum creatinine. What you can see is that the serum creatinine starts rising above normal, below eGFR of 60. So if you have kidney disease here between 100 to 60, you are not going to miss it if you are just relying on serum creatinine values. And the urea actually rises even much later. So that's why we have moved ahead now, and we no longer depend on urea and creatinine to talk about eGFR. And this is, how do you do it? It's very simple, and I'll come to that again. But these are the perils of using the serum creatinine to guess the level of renal function. So 24-year-old man with a creatinine of 1.3, and all these look seemingly normal. At least when I was doing, we used to consider them absolutely normal. So let's see, in a 24-year-old man, this means that the eGFR is more than 60, and if there is nothing else, if there is no microalbuminuria, there is ultrasound is normal, then you don't have to bother. You can just tell him that relax, this is okay for you. But a 63-year-old man with a serum creatinine of 1.3, same serum creatinine, eGFR is 59. So if you confirm it again over a period of 3 months, then you don't need anything else. You don't need an ultrasound, you don't need a urine examination. This patient has got chronic kidney disease. And an 80-year-old lady, serum creatinine 1.3, eGFR is just 42 mils per minute. So this is already, we are dealing with stage 3B. Now, this eGFR looks very cumbersome, but today technology has made it very simple. And these are calculators. This SciMed calculator is available. MedCal is available for free. So you can actually download it on your phone, and you can hand it over to your paramedic. So before this patient comes to you, you just have to plug in. So I'll show you this patient, 63 years age, weight was 85 kg, serum creatinine of 1.6. As you can see, it gives you all the different formulas, but this is what each GFR-MP which we use, 45.2, and this is the staging as per Ckd stage 3A. Very simple to use. This is MedCal, so it's easily downloadable, very easy to use, and in fact, all laboratories should be reporting it. I mean, you shouldn't even burden your clinicians. And in Fortis Hospital, Vasantkunj, for last 20 years, if you just ask for a serum creatinine, you get an automatic eGFR. Children, again, there is a caveat here. We need the height of the child also. And there's a different formula, but again, that is there on the calculator. So that is one thing you can take home, a very simple, easy to use. Now the prognosis of Ckd. This is how we stage Ckd. So depending on the GFR, G1 is more than 90, but here you need some other abnormality like an ultrasound of proteinuria. G2 is 60 to 89, G3 is 45 to 59, G3P is 30 to 44, G4 is eGFR 15 to 29, G5 is less than 15. And this is the degree of albuminuria. This green area shows low risk, this is intermediate, and this red area shows really high risk. So this is what we call the heat map. So if you are in this zone, you can warn your patients that you are going to land up in stage 5 chronic kidney disease if you don't alter your course. So this is again the frequency and referral. If you pick up all this, I think it is always wise to, if you think that you have a patient of chronic kidney disease, please get it validated by a nephrologist, because if you don't do so, this patient is going to go to some Baba or alternative therapy practitioner, and he's going to mess him up. So coming back to this patient, 63-year-old male, 9 years, diabetes, serum creatinine of 1.3. The first time we did the eGFR was 59. So we followed him up. We said he might be having chronic kidney disease, and we called him. I saw him 3 months later, and the serum creatinine was still the same. So this patient had chronic kidney disease. The edema was again due to chronic kidney disease. Now, this is a study which we did at Fortis Hospital. What we did was we picked up 774 patients who had come to our for preventive health checkup. So people come for PHCs just as a matter of habit, or sometimes they are mandated by their employers and they just go back. So what we found was, we just went into their records. 9.56%, 74 of the 774 patients had chronic kidney disease. They had actually gone back. They had not seen us. And these are the stages. The majority of them is stage 3, and some of them is stage 1 and stage 2. And this, why had they not been to a nephrologist? Because all these stages are silent chronic kidney disease. You don't develop symptoms. So another take-home message is that don't wait for symptoms. You have to screen for chronic kidney disease. You have to look actively and try and find it out. Symptoms come usually in stage 4 and stage 5, very late. And by that time, there's very little we can do. Now, what is the clinical approach? So a lot of times people ask, what are the warning signs of kidney disease? Well, high blood pressure can sometimes be the only sign of the underlying kidney disease. I know we have all been tuned during our residency time. The moment you have blood pressure, we send him to a cardiologist. But the cause of blood pressure actually lies in the kidney. Even in essential hypertension, it is the dysregulation of the sodium reabsorption at the level of the nephron which causes hypertension. You have excessive sodium reabsorption, more sodium in the body, you develop hypertension, and you develop nephrocirrhosis. So all patients with high blood pressure should have CANs. Other ways also true. High blood pressure is one of the top 3 causes of chronic kidney disease in our country. That's why all hypertensives should be screened for chronic kidney disease, and you'll be surprised, majority of them will require a kidney referral. Again, if you have proteinuria, blood in the urine, obviously you have kidney disease. Creatinine and blood urea nitrogen tests outside the range. Glomerular filtration rate of less than 90. More frequent urination. These are non-specific symptoms. I know all of us will have seen such patients. We sometimes label them as BHP, but you do eGFRs, you'll be surprised. A lot of them have like chronic kidney disease. Puffiness around the eyes, swelling of the hands, feet, classical symptoms, usually stage 4 or stage 5. So symptoms, again, do not wait for symptoms, screen them. Now, this is a study which was published in Lancet in 2008, but still very relevant even today. This is a study from US looking at nearly 500,000 individuals, more than 20 years, follow-up of 13 years. The prevalence of chronic kidney disease was nearly 12%. But here, even in this so-called land of the enlightened, only 3.5% of the patients were aware of these disorders. What was remarkable was that this subgroup of patients had an 83% higher mortality and 100% higher mortality for cardiovascular disease. Chronic kidney disease now by 2040 is going to be the number 5 cause of mortality in patients in the population. So if we have to lower mortality, we have to make an early diagnosis. and the mortality is usually cardiovascular nature. So very important for the cardiologist to that if you have to screen patients for cardiac disease, just do a eGFR. There's another study from Italy looking at there the prevalence was 23%, but the physician diagnosis was again made only in less than 4% because they were relying on urea and creatinine values. Not surprising. And blood pressure control in patients with chronic kidney disease, which I think is one of the most important things you can do. As you can see in this study, was just between 10 to 13% because most of these patients were not aware. So if you have chronic kidney disease, then you have a totally different set of targets for your blood pressure. And I'll share with you that, but much more stricter control. Now, Ckd and cardiologists. So if you have stage 1 chronic kidney disease, the mortality rate is already four times higher. Stage 2, 70, where the GFR is 70 to 89, 8 times higher, and less than 70, which is again stage 2, nearly 20-fold higher. So the hazard ratio of a patient who has got eGFR less than 70 as compared to more than 90 is 1.68 times. So that's why I think even for the cardiologist and even on a population perspective, that if we have to lower the mortality, improve the cardiac outcomes, we have to know what the eGFR is concerned. A word about Ckd and obstetrician. How is it important? This is the effect of pregnancy on renal function. Accelerated deterioration of renal function occurs in some patients with chronic renal insufficiency. Prognosis depends directly on the degree of renal dysfunction at the time of conception, without the underlying kidney disease. So, and as well as the presence and extent of comorbidities, namely hypertension, proteinuria. So always in your preconception clinics, the obstetrician need to look for hypertension, proteinuria, and eGFRs. And renal function is most likely preserved in mild renal insufficiency. So this is a study by Katz et al. Mild renal insufficiency, 16% here had a decline in renal function, and 6% of these even here progressed to peripartum end-stage kidney disease. So if you have this, we need to counsel our patients. So because pregnancy, you have slightly lower creatinine values. 1.5 to 2.4, 20% of the patients progress to end-stage kidney disease within 1 year, and more than 2.5, 45% progress to end-stage renal disease within 1 year after delivery. This is a study by Cunningham et al. So that's why in today's medico-legal era, very important to counsel these ladies who are planning pregnancy, because otherwise, as is evident, the blame comes on the doctors for anything that goes wrong. Now we need a team of, in today's era, we need a team approach. Why? Because we are confounded by alternative therapy practitioners and the media, and we also have our limitations. So physicians, we know everything but often end up doing nothing. Surgeons, in contrast, know nothing but do everything. Dermatologists, I think, know nothing, do nothing, get their patients get better. Pathologists are the most knowledgeable of the lot. They know everything, they will do everything, they will tell you the diagnosis also, but sometimes a day too late, that is autopsy. Now, this is the need for early referral in CKD process. These are the different stages, percentage of kidney function. Endocrinologists, or you can, if you are managing a diabetic patient, you can treat down to stage 3A, but beyond stage 3A, you should be getting a nephrologist. So when to refer to a nephrologist? First at the time of diagnosis. And thereafter, once the eGFR is less than 30, dramatic increases in the albuminuria are there. If there is anemia, which you cannot explain, if there is uncontrolled blood pressure, if there is a rapid worsening of CKD, this even in the Western scenario are absolute indications. But I would add one here that the moment you diagnose CKD, get it validated by a nephrologist. And this is again a study published in Postgraduate Medicine showing the continuum of care interaction between the primary care physician and the nephrologist. So stage 1, stage 2, stage 3A, primary care physician is the frontline physician. The nephrologist is there holding his hand at the back, validating the diagnosis with intermittent follow-up. But the moment it crosses into stage 3B, the nephrologist should take over, because we have to start vaccination, we have to start counseling for vascular access, counseling for transplantation, and try and talk about preemptive transplants also in this set of patients. So CKD is a disease which has got high prevalence but very low diagnosis. So the prevalence is on, the pressure is on to diagnose CKD, and you should remember CKD as C for check EGFR, K for kick off a conversation with your patient at this stage, and D is diagnose early, as I told you by some of the tests that I showed. So what can you all do? I think you can do a lot. Recognize and test at-risk patients, so all diabetic patients, all hypertensive patients, all patients with cardiovascular disease, those who have had kidney stones, those who have neurological diseases like SLE, rheumatoid arthritis. Educate patients about CKD and treatment. Manage blood pressure. If the patient has blood sugar, strict control of blood pressure and blood sugar would add significantly years to the life of the kidney. Address other cardiovascular disease factors like obesity, smoking, dyslipidemia. Monitor EGFR and ACR, and as I said, these are the guidelines that we need to encourage our labs to support the test. I'm not aware whether the labs in this city are reporting, but now in Delhi it's become a norm. All good labs are reporting EGFRs, and I hope the same is true here. Again, we can look at anemia, look at other causes, look at malnutrition, which actually is very prevalent in our country, because the moment you have a diagnosis of CKD, they go on to the net or they go to an alternative therapy practitioner who's going to totally cut down protein, and the creatinine is going to come down. Patient is going to be very happy. That's the reason these people are so successful. But we have to educate these patients that you are going to develop malnutrition, develop one infection, and the kidney function is going to get knocked off. So if there is a dietitian available, refer to her for nutritional guidance. There is no role for protein restriction in a vegetarian diet. Our vegetarian diet is already a protein restricted diet. So the guidelines for a CKD patient are 0.6 to 0.7 grams per kg, depending upon the different stages of CKD. And today, if we can go home and calculate our protein intake as a vegetarian diet, mind you, vegetarian is a low, as such a poor biological value protein. Most of us would be definitely under a gram. Consider patient and safety issues. Consult or team up with a nephrologist. As I said, co-management is very important. Refer to nephrology when appropriate, certainly at the time of diagnosis, definitely below EGFR of 45. So this is what, if you diagnose early and how you can make a big difference. Again, this is a study published in American Journal of Kidney Disease. So this is a patient whose EGFR is declining. He doesn't know that he is CKD, so he might take NSAIDs from a friendly pharmacist without knowing EGFR, and the kidney function is going to crash with just one tablet of an NSAID. And I see this, I'm sure both Arvind and Anurag will vouch for this, that they see patients like this who have not even consulted a physician, just picked up a tablet of Profen sitting at home, and the kidney function declines. This patient, as I said, might land up for a contrast study, has got a contrast procedure without doing the test. So kidney function worsens. Aminoglycosides, fortunately rarer in our country, or somebody's given the urine output is declining, and you give diuretics, patient develops hypotension and progresses to end-stage kidney disease. But yet, if we have done the EGFR and we are controlling the blood sugars, we are controlling the blood pressures, we are controlling the proteinuria, the same patients are the kidney is going to survive much longer. So this is the impact a primary care physician can do, and it is essentially preventive nephrology, which I think none of the nephrologists can do so, because they are too burdened with stage 4, stage 5 kidney disease. So this is a chart, what you can do. Strict blood pressure control, target blood pressures of 130 by 80 or even 120 by 75 if you have higher proteinuria. So greater the proteinuria, stricter the targets. Good blood sugar control. So many studies, the DCCT and the UK PDS trial has already shown this. If you have proteinuria more than 1 grams, definitely use ACE inhibitors, angiotensin receptor blockers, and now we also have the SGLT2 inhibitors. Regardless of whether the patient is diabetic or non-diabetic, you should be using these drugs to reduce proteinuria. Look at anemia. Anemia contributes to cardiovascular mortality, contributes to faster progression of kidney disease. We now even have oral agents now available to treat anemia of chronic kidney disease, but that's a subject of another talk. Bone disease, I think osteodystrophy is easier to prevent but very difficult to treat. So in the earliest stage, control the phosphate, use phosphate binders, you use activated analogs of vitamin D, and if you have severe hypoparathyroidism, we now have cinacalcet available, and certainly target the lipids to reduce the cardiovascular mortality and to some extent slow progression. when to offer dialysis or transplantation. Preemptive transplantation, if the EGFR is less than 10, there are no reversible factors. Earlier in diabetics, even at 15 to 20, and also in children. Or if you have symptoms and signs of uremia and malnutrition, then obviously dialysis or transplantation would be the only way to go. So the options for stage 5 chronic kidney disease, still renal transplantation is the gold standard, offers the best quality of life, also economical. The cost of transplant is about a year's cost of dialysis, and it offers complete rehabilitation. We have several patients who have received kidney transplantation and are now useful members of the society. They are earning for themselves and for them supporting their families too. So they're supporting their own medication, which is obviously a lifelong immunosuppression, but at the same time, they're supporting their parents too. In contrast to patients on hemodialysis, so hemodialysis is like an attempt to buy time, a default treatment if there is no suitable donor available, or there are some cardiac contraindications, patients are not convinced. Continuous ambulatory peritoneal dialysis is another mode. Patient can do it at home. So these are the two other options. Kidney transplantation, as I said, is the gold standard, but a word of caution to all my patients, a quote from a famous transplant surgeon, Richard, that kidney transplantation is like marriage. It means benefits for many, curse for some. Some patients definitely develop infections, develop rejections, but risk for all. So there is a lifelong risk, but I think the price is too small to pay, just like marriage. It is worth everything. So end-stage kidney disease cannot be treated with conventional medical treatments such as drugs. We need to educate our patients. Every day I get, on my WhatsApp videos from people circulating on the social media, viral videos that, can we do this? There was one video which said that you put some bricks under your cot, the kidney function is going to improve, one patient. And these are knowledgeable people who are asking me, and educated people. And the answer I told them was that if the bricks can do this, the bricks should be worth their weight in gold. So this is why all of us need to work together to counter this threat. The social media has, I think, become one of the biggest threats to scientific therapy. So there are only two treatments we need to tell our patients, and whether you're a surgeon, whether you're a physician, whether you're a pathologist, it's everybody's job to educate the people, to keep them so that they can stay away from these quacks, preserve their finances so that it can be used when it is required. Because by the time they come to nephrologists, and again, both Dr. Anurag as well as Arvind will vouch, they're totally depleted. Because why? Because 6 months they have spent lakhs with all these touts available. Now, just a brief comparison about dialysis and transplantation. Annual mortality rates for patients in dialysis are 21 to 25%. So you start 100 patients on dialysis, at the end of 1 year, 75 will be alive. If you get a cadaveric transplant, rare in our country, but still worth it, 92 are alive. With a living related transplant, 96% alive. By the end of 5 years, 20% of dialysis patients are alive, even in the best set of patients, but of our transplant patients, 80% are alive with a normal kidney function. So that's the difference between a dialysis or a kidney transplant. And the benefits are most noted in young people as well, or those on dialysis. So this is on dialysis, your best survival in a non-diabetic would be 20 years, and in a transplant, at least 31 years. In a diabetic patient, just 8 years on dialysis. Again, these are all Western figures. Our figures are 50% lower. 25 years if you go ahead with a transplant. So 3 times better survival in a diabetic patient. Transplantation is not new to our country. In mythology, we all know that Lord Shiva was the first to transplant the head of an elephant, or Lord Ganesha. It offers potential improvement in quality of life, patient survival. The goal is to avoid rejection, to minimize complications, and to achieve long-term graft survival. And today, with the benefit of modern immunosuppression, we have excellent long-term graft survival. So who are the patients who are suitable for kidney transplantation? All patients with end-stage kidney disease, unless there are specific contraindications. If a patient has malignancy, then this patient has to be first treated and should be malignancy free for 2 years. But then even after that, and we have done these transplants have been done very well. Chronic infection, a very short relative disease. So if you have tuberculosis, you start them on antituberculous therapy, and after 1 year, 1 month, we reduce the medication, they can go ahead. Hepatitis B and C are no longer contraindications because the outcomes on dialysis are far worse. Severe cardiovascular disease, definitely yes, because if they cannot withstand anesthesia, they first need to undergo either a bypass, or a CAG with a PTCA, so that we stabilize their heart function, and then they can go to the kidney transplant. Neuropsychiatric disorder is one thing we are all very cautious about, because these patients require lifelong immunosuppression. So we can't risk a kidney if the patient has not got enough cognitive function to understand the importance of taking regular immunosuppressive therapy day in and day out. Even missing a single dose can cause it. Neuropsychiatric disorders are excluded. Extremes of ages are relative. Today we are doing transplants in geriatrics, and in our experience, the oldest transplant that we did was 83 years. So the rule of thumb is that if their average survival is about 2 years with CKD, we are expecting at least a minimum of 2 years survival, then we should offer them kidney transplant rather than dialysis. These are the principles underlying immunosuppressive therapy. The benefits are you have to take lifelong therapy indefinitely, but the benefits outweigh the risks. Multi-drug regimens are generally employed, learning from our oncology colleagues. We use large doses initially for the first 3 months. After that, the doses come down, so the cost also comes down. And by the end of 6 months, you are down to a very, very low maintenance dose. Donor, I think, is one of the biggest issues because as per the Human Organ Transplantation Act, we have to take a donor only from the family or the extended family, first degree or second degree relative. So it has to be a blood relative, first degree, second degree patient. The person should be highly motivated, excellent medical condition with normal renal function, and negative cross match, which means that we do a blood test of the donor and the patient. So we mix the serum of the recipient with the donor lymphocytes, and if there is lymphocyte destruction, that means that there is a high risk of rejection. So this is an absolute must. And blood group compatible, yes, we used to do that, but now even we can do transplant even if there is no blood group match. But yes, the cost goes up and there is a higher risk of infection for sure. HLA is no longer important. The commonest donor today is either a wife to husband or husband to wife, because the small family now, you just need a higher degree of immunosuppression. So HLA is no longer. So these are the high-risk transplants, and we are currently doing all these pediatric transplants. The youngest transplant that we have in our experiences was a 4-year-old boy from Varanasi. He had not started his schooling, and today he's into college and having absolutely no, and has had an excellent academic career, always stood first in his class. So that is what transplants in child can do. ABO incompatible transplant, we can do kidney swapping. So between two incompatible pairs, if the blood groups are not matching, the law does allow to exchange blood groups. Transplants can be done even in patients that are HIV positive, and we have done several such transplants. So which seems like a paradox, because HIV is an infection, a chronic infection, and you are doing a transplant. The outcomes on dialysis are far poorer. But if the HIV infection is well controlled, the viral load is under control, you can do kidney transplants. And lastly, COVID was a big learning for us. Initially, when the COVID pandemic came, we all stopped kidney transplants all over the world. And gradually, with bated breath, what we found was that the mortality in dialysis was very high. And the transplant programs restarted with very strict standard operating procedures. And at Fortis, so far we have done, ever since the start of pandemic, close to around 150 transplants. Thankfully, none of these 150 developed COVID infection during the hospital stay. We had a few patients who have developed, about 4 or 5 patients who developed COVID infection just after discharge, but their course has been milder. In contrast, those patients who had transplants long time back, who had a very high cumulative immunosuppression, who had a very high incidence of comorbidities, those are the patients who have not done well. And we had a very high mortality in that subgroup of patients. And obviously, dialysis patients, mortality was as high as 25 to 35%. So transplantation, even in COVID times, is this optimal way to manage stage 5 kidney disease. So to conclude, despite multiple therapies, both pharmacological and behavioral CKD occurs and CKD progresses. There is a huge unmet need for a better strategy. So the cardiologists, the nephrologists, the diabetologists all need to work together because hypertension and diabetes are the commonest causes, and a lot of these patients have cardiovascular disease along with the physicians. The benefits are there of early detection and treatment, proper investigation and accurate diagnosis, definitive diagnosis relevant for specific disease treatment like acute glomerulonephritis, also for future transplant. So the nephrologist can help you with a kidney biopsy, and we can also screen relatives and counsel them, allow measures to retard progression as I showed you, and look at complications associated with failing renal function like anemia, renal bone disease, and malnutrition. Benefits of early detection and treatment enables timely referral to a nephrologist. So you have adequate time for preparing patients for renal replacement therapy, talking to them about transplant or dialysis, create AV fistula, vaccination, placement of catheters, avoids increased mortality and morbidity associated with temporary dialysis catheters and intermittent peritoneal dialysis. These are studies have shown that those patients who came late had a several-fold higher mortality as those patients who were referred to a nephrologist earlier. So to conclude, we need to make an early diagnosis of chronic kidney disease by screening high-risk patients. Tests are very simple, cost less than 1,000, available everywhere. We need to have nephrology referral with a collaborative approach. Look for reversible factors. That's very important. A lot of these patients, the kidney function is going to improve. 1/3 of our patients have some reversible factor, and if we correct acidosis, correct improve proteinuria, control blood pressure, sugar, the kidney function gets better. And these patients are very happy for you. We can put into place measures to retard progression, which I mentioned. Discuss well in advance options for renal replacement therapy by kidney transplant, and we can now do transplant across blood group. So we have broken the blood group barrier, and in times to come, I think xenotransplantation or organs from animals are going to become a reality. The first one was recently done in a brain dead individual, just as a proof of concept in US a few months back. And I think in the next couple of years, we are eagerly looking forward to address the shortage of organ donation. And this is a work which has been recognized by the Vice President of India. And I end on this note by Robert Frost that a lot has been done, but a lot more needs to be done. And we have promises to keep and miles to go before we sleep and miles to go before we sleep. And this is my YouTube channel, which I have put into place during the COVID pandemic to counter all the misinformation that is there on the social media. I'll encourage each one of you to actually have your own YouTube channels to educate your patients, or at least give them the appropriate channels so that they can educate themselves, because on the social media, it is not the quality of work, not your degrees that are important. It is the following, the number of followers, that is the most important. And you know, in today's world, you can purchase any number of followers you want. And that is why that is what these alternative therapy practitioners do. And that's why they are so popular on this social media platforms. Thank you. So if there are any questions, I'll be happy to take.
Thank you, Professor. Knowledgeable and knowledgeable.
You can just sit there and
must have insight to the management. I have a question for you, sir. And the question is painkillers. And I think this has to be done with almost all the whenever you evaluate on kidney diseases. What painkillers are safe? Number one, we as a physician, then the practitioners of the physicians and all other give for some time, say for 1 week or 5 days. But the orthopedics, they are those studies have been seen them practically for 15 days, 21 days, and then the patients are continuing with those drugs as well. So what is your take home message for these?
That along with appreciation that always I see especially in this one like this and from there is a lifelong
I think it's very important before you prescribe NSAIDs, you have to know the EGFR. Very important for the patient also. Because They are got it. There was this patient with trauma, severe pain, and at that time the entire focus is there on the pain part, but very often they forget it. We have had several patients, several referrals from our office. This patient has suddenly got kidney damage. The chronic kidney disease cannot occur suddenly. It is what silent kidney disease, and there are only two painkillers which are absolutely safe for 3 items that government also. The first one is paracetamol. You can use safely. Second is tramadol, often in combination with paracetamol, and third is gabapentin. The other than that, even the single dose, I repeatedly said, if the patient has say EGFR 45, 60, and you use single dose of painkiller, the patient's kidney function better.
Thank you, sir. Now the house is open for any question answers for the audience.
Okay. We should just read first about how conduct urine examination and when to look for when you are looking for abdomen and when you are looking for RBC. You will tell patients with UTI or severe sepsis. The main concern is proteinuria. Looking into that. Many things they are more worried about proteinuria their conditions or their practitioners about cells RBC. So, we have a message for interpretation of examination.
So, urine examination again, I could be one of but it's also become very simple to detect proteinuria because the states are there. So, even if you can keep a dipstick bottle there in your side lab, and just do it, and you can screen for proteinuria level. Microbiology screening can be done. The Indian Society of Nephrology for that. So, we have now initiated, along with one of the with a grant from one of the pharmaceutical concerns, healthcare screening at the community level now with the help of these districts. There's a big study that is going on. I think in a year's time we should be able to have some data, Indian data now, chronic kidney disease. But you were surprised to know that about 50 existing studies tell us that 50 to 70% is the community prevalence of chronic kidney disease in our country. Which means that after of 100 people in the community, not those coming to your clinic, 100 people in the community that are there in your neighborhood, 15 to 17 are going to have some degree of chronic kidney disease. So, anemia, I think, is very important. Urine routine for cellular class again is important, but many times we are fixated on some 8 to 10% in complication. We see a level of UTI. RBC is definitely a much more important, but sometimes we can have transit. Microhematuria, just your repeat sample of RBCs disappear. But anemia, I think, between already what if you have to look at one thing in the urine, and that is the anemia. That is very simple to do by this.
Can I ask a question? This you have mentioned about pregnancy, disease. What we have seen, I'm an ophthalmologist, what we have seen is that there is a correlation between diabetic retinopathy and nephropathy. So, what is your opinion about that? And at the same time, I would like to suggest to you that you keep Ckd.
Point higher. Yeah, point well taken. I think ophthalmologists are our biggest friends. Everyone will tell you. Every diabetic patient mandates an ophthalmology. Every diabetic patient. Because that diabetic comes to me, I immediately send it. Because, as Dr. rightly said, if you have retinopathy, you can put your money, you can bet your money that this patient is going to have chronic kidney disease. There's an excellent correlation. So, just screening for proteinuria, it also helps us in segregating diabetic from non-diabetic proteinuria also. So, if you have proteinuria, you don't have retinopathy, then these patients should be biopsied straight away. Because you will have because of non-diabetic kidney disease, which should get some regular practice. So, yes, point well taken, it should be Ckd.
And Gupta, seeing you after 30 years. Good to see you. And those days you used to fight about protein that specifically now. But our patients more and more and more your patients
staff community. So it was good knowing that you have somewhat come to us and allowed higher protein. So, but my question is really much more protein than what you recommend. Say 80 grams of protein in chronic liver disease. The other thing is, it's a very difficult thing to manage a patient with chronic kidney disease and chronic kidney disease, which seem to coexist because of the diabetes, NASH, NAFLD, chronic liver disease, and chronic cirrhosis.
So absolutely, I think those are the most difficult patient studies. Like, I would take one patient which I would like to refer to my nephrology colleague. It would be a patient of chronic kidney disease with chronic liver disease. So these are, very complicated patients, always managed with the in connection. Many times, even when we manage these together, the outcomes are really poor in these patients. So these patients are heading towards, most of them are heading towards a combined liver kidney transplant, which is well beyond the reach. So in these subgroup of patients, it's you have to walk the tightrope. You have to give a very high quality of protein, and yet you cannot afford to go overboard because the kidney disease worsens. And if you give too little protein, then the ascites worsens, and they develop malnutrition, they come in with repeated ascites. So I agree with this. Very complicated set of patients. I think only the hepatologist and gastroenterologist can manage them adequately.
Now, there is another question for me, both for Dr. Sanjeev and Dr. Gulati is also here. Dr. Sanjeev, you said paracetamol is the safest for kidney. In COVID period, we had an experience that it was used very widely. I mean, almost everywhere, everybody was using paracetamol for fever control. And there were a lot of reports about liver damage, which was for me. Earlier, it was not to be safe for liver, but there were so many reports in COVID period. So I would like to know that your game of Rohit about this. If you prescribe it for safety of kidney, are we doing it at the cost of liver damage?
So I think Rohit is more confident to give you the upper limit of the safety dose. If you exceed any drug, any dose, you will develop complications. So any drug has to be used within the recommended doses. All I can tell you is from the kidney point of view, it is the safest. But Rohit tell us what is the upper limit for on a daily basis, and for how long do you think is what dose would you suggest?
I think it's very safe. Safest drug that we have. You can use it, say 650 grams thrice a day is good enough for most patients, and up to 2-3 grams is good enough. The same countries where transplant poisoning is there, they have it at around 10 grams. That is very high. So, generally, the usual doses which we use are quite safe. Much safer than any other medicine.
So, the little failure you might have seen during COVID, particular other comorbidities. Up to 4 grams, we should bother. Proceed, there are more than that. So that is absolutely safe. Rohit is validated. I think it's one of the safest.
So weight wise, paracetamol is 60 to 16 milligrams of the body that you can go for. Yeah. So what advice do you have for colleagues of my colleagues who have significantly damaged or so? Should they continue?
So if you are not a diabetic, again, after this, I'll ask Rohit to comment on that. But from kidney's perspective, by and large, alcohol is relatively safe. Again, is the word relative. Yes, if you have hypertension, all I tell my patients is that you're going to take salty snacks with alcohol, then better not take alcohol. Now, if you have some degree of kidney damage that is already pre-existing, then depending on the potassium dose, you have to choose your drinks a bit more carefully because beer is like for higher potassium dose. So we tell our patients don't totally, and you can have your occasional drink, but as it could this year or vodka. But as far as the safety of alcohol, you know,
alcohol is for liver is not very good, but if somebody is consuming alcohol and liver function test, then he can continue. Once, whenever he has some problem or whenever he has some disease, then he should be stopping it, then rechecking it and doing the cause. Alcohol is not the cause, remove it, and then you can try once more. Amount of alcohol is not very good for you. Still, the final return has not come. How much or but still, any good hepatologist would not.
thank you, sir. Thank you, Dr. Gulati. A big round of applause for Dr. Gulati.
Thank you, sir, for an excellent session. I think there were so many take-home messages. Just to enumerate some, for all our early care physicians, treat wisely, tightly your blood pressure and blood sugar. Keep on monitoring and just give more emphasis to eGFR, and hence the kidney remains safe. And we have our nephrologist in a city who will be there to guide us if we get stuck somewhere. So thank you.